let's move to the first panel of the afternoon, and this is on learnings from big data from the pandemic. And our moderator for this panel is Dr. Ajay Nair, the CEO of Swasth Alliance, a non-profit health collective that builds digital health infrastructure and standards for public good. He's been an advisor to digital health innovators, advisor to non-profits, governments. After this is co-founding and leading one of India's first telemedicine networks called Mera Doctor. And prior to this startup journey, he was a social impact investor as well at Acumen Fund in New York and Nairobi, focusing on health and energy. And as a doctor, he's also helped set up and run HIV or STD clinics for male and female sex workers in Mumbai. He has an MBBS from Grant College, Medical College, and an MPH from Harvard University. He's a fellow of the 7th class of the Kamal Nayan Bajaj Fellowship within the Aspen Global Leadership Network. On that note, it's over to you, Dr. Nair, and I know that you'll be introducing your panelists.
Thank you so much, and thank you everyone for joining this session. And thank you for joining the special panel on big health data learnings from the pandemic, functioning disease surveillance system. Data has various uses in the public health context and comes from a very wide variety of sources. It could be population surveys, registration of vital events, disease surveillance and notification system, routine reporting from health services or real world data. There's also new kinds of aggregate data that we've seen being used in the pandemic. We've seen mobility data from telecom companies, platform providers like Apple and Google. And this data has various uses beyond early warning and pandemic management, from drug discovery and development to improve targeting of health and social inequities. And we've all heard this cliche about data being the new oil or the new gold. But we've also just heard Dr. Kang say that most of the data we rely on in India for decision making actually comes from high income countries. So the questions, we need to ask ourselves is not just, what does the data say, but also the question is, how has data helped us so far in the last 2.5, 3 years of the pandemic? What have we learned about how to collect and use data? And how does data lead to evidence and decision making? And so with that, let me just quickly introduce this very eminent panel that we have here. I'm going to step back and take a passive role and let the panelists speak for themselves. I'll very quickly introduce the panelists, and then we'll have a free-flowing session. Please keep your questions coming in the chat box. We'll try and pick them up as quickly as we can. So on to the panelists, we have with us Dr. Professor Manendra Agarwal, who is the head of Department of Computer Science and Engineering at IIT Kanpur. Professor Agarwal has made significant contributions to the theory of efficient reactions between computational problems, which are part of the problem studying the well-known P versus NP question in mathematics and computer science. He co-created the AKS primality test with Neeraj Kanyal and Nitin Saxena, for which he and his co-authors won the 2006 Fulkerson Prize and the 2006 Godel Prize. He was also awarded the Clay Research Award for his work in 2002. Welcome, Dr. Agarwal. Joining us next is Dr. Chandrakant Laharia, who's a medical doctor, vaccines, public policy, and health systems expert. For 13 years, he coordinated the World Health Organization's work in India on new vaccine introduction, routine immunization, health system strengthening, and universal health coverage. He has done extensive work on India's COVID-19 pandemic preparedness and response, including the COVID-19 vaccination rollout all India. Welcome, Dr. Laharia. Our third speaker is Gautam Menon, Professor of Physics and Biology at Ashoka University. Prior to joining Ashoka, he was a professor at the Institute of Mathematical Sciences in Chennai. He completed a BSc Honours in Physics at St. Stephen's College in Delhi, an MSc from IIT Kanpur, and a PhD from the Indian Institute of Science, Bangalore. Following postdoctoral work in Mumbai and Vancouver, he joined the Indian Institute of Mathematical Sciences. He works on a number of biophysical problems, including nuclear architecture, axonal transport, collective cell migration, and cell division, all in the general field of mechanobiology. The modeling of infectious diseases and its implications for public policy is a long-standing interest of his, while the use of machine learning methods in clinical context is a recent one. And welcome, Professor Menon. Our fourth and final speaker for the panel is Dr. Tanu Singhal, who is a consultant pediatrics and infectious disease at the Kuklaben Dhirubhai Ambani Hospital and Medical Research Center in Mumbai. Dr. Singhal has been associated with the Kuklaben Hospital since inception in 2009 as a consultant in pediatrics and infectious disease. She received training in pediatrics at the All India Institute of Medical Sciences in Delhi and in infectious disease and international health, London School of Hygiene and Tropical Medicine in the UK. She acquired further expertise in pediatrics and infectious disease at Hinduja Hospital in Mumbai. She has to accredit 2 books, 20 book chapters, 65 publications in indexed national and international journals, and several hundred guest lectures. Dr. Singhal is an advisor to the ICMR on antimicrobial stewardship, a technical expert in pediatric tuberculosis for the National Tuberculosis Control and Elimination Program, and also an executive board member of the Fungal Infection Study Forum. So with that, welcome, Dr. Singhal. So as I mentioned earlier, I'll step back and I'll let the panelists speak. I'm sure we'll have a very exciting discussion. I had a quick chat with the panelists before, and what we talked about was if they could walk us through their journey over the last 2.5 years as it relates to data and health. They are all either prominent consumers or creators of health data, and talk about their journey and then talk about the learnings. We'll also briefly touch upon this controversy around the methodology for measuring the death counts in India, probably at the end of the session. So I'd like to start with Dr. Agarwal, and I know, sir, you have some slides. Go ahead, please.
Thank you. I'm going to share a few slides on data and the COVID pandemic. First of all, thank you for having me on this panel. It's a very topical one and very interesting one as to how data can and has influenced our understanding of the pandemic. So the approach I'm going to take is that how the data that we have received, how that has helped in our understanding of the pandemic. And second, what more data, had it been available, would have made things even better. Let's start with what was available and what was its use. So if you look at availability of data, there is something remarkable that happened this time. Across the countries, we had daily new infection and death time series available. This, I don't think, has ever happened in the past. Probably 100+ countries were every day reporting new infections and deaths. And when you come to India, of course, we had this data not only for India, but at the state level. All states were reporting this. And if you go down further at the district level, most of the districts were also reporting. And our estimate, 70+% of districts did report in certain way the new infections and deaths. So that's a huge data and very interesting data. What use can we make of it? Here is an example. This is a study we did using our Sutra model. And the topic of study was how has Omicron mutant caused immunity loss? So there are 2 types of immunity that here we are talking about: vaccine-induced immunity and natural immunity acquired through a past infection. So what we did was we took 27 countries, which represent about half of the world's population. And we had to cut out many countries. For example, countries following zero COVID policy or placing too many restrictions were not amenable to such a study. So we picked up more populous countries with a significant population, which had satisfied the certain requirements that we had. And if you see this plot, this is a plot on the y-axis you can take roughly the loss of immunity that has happened in percentage terms. And in the x-axis is what were the percentage of vaccine-only immunity in that country. And you see quite a remarkable match here. It's a direct correlation between the loss of immunity and the amount of vaccine-only immunity, with a very high R-square value of the fit. So what this tells us is that the vaccine immunity was quite significantly bypassed by Omicron. Of course, it has been confirmed by certain other studies as well, but this is a data which you can take across the country that provides a very good picture of what has happened. Even more remarkable is the next study, which plots loss of immunity against natural immunity present in the country. And here the picture is totally inverted. There is a very strong negative correlation between the two. And again, a very good fit of basically telling us that the higher the natural immunity in that country, lower was the loss of immunity. So what we can draw conclusion from this is the vaccine immunity was more or less bypassed by the Omicron. Now, of course, here I don't mean that vaccines are useless. Vaccines did protect and continue to protect against serious infection. But here, what I'm focusing on is ability to infect. So vaccine against Omicron were not able to stop infection. On the other hand, natural immunity was very good at stopping even infection by Omicron. And that is shown by this study of data across the countries. So that's kind of information you can extract if you have this kind of data available. Now, coming to the quality of data, there has been a lot of discussion around that as well. We had a look at the Indian data and compared the data with other countries, and we found that Indian data reporting is better than most of the countries. Just to give you an example, here is a UK data. The entire timeline of daily new infections averaged over 7-day weekly period, so that weekly variations are smoothened out. And you can still see a lot of jagging up and down. It's small, perturbations. And then there is a big stuff here. Even if you ignore that, there is quite a bit of jitter in this data. Look at the US. Again, less jitter, but still the jitter is present all across the timeline. Compare this against India. Much smoother data. There is some jitter, yes, but a lot smoother compared to the US and UK data. So what this tells us is that in the reporting of data in India was a lot better. Whatever the strategy or policy was being followed to report data, it was very consistent and implemented across the time in the same way. So that's another thing that you can learn by just looking at the data which is available. Now, coming to what are the limitations of that we have seen. District level data, if you look at India, it required a very significant effort to extract. When I say that 70+% districts reported data, it was not a very simple reporting. In fact, the volunteers in COVID19.org spent uncountable hours in trying to extract and collate and make sense of that data. And since they stopped working, and then a lot of district data stopped coming. More than that, many states never even bothered to report district level data. Andhra Pradesh is one example. So that's been a drawback. And if we have this full data available, what we can do is we can actually study how the mutant, either Delta or Omicron, has spread from district to district across the country over the timeline. We are still doing that study, but it will be limited to the districts for which we have it. Mortality data that was already alluded to, and there is a lot of controversy around it. A huge uncertainty about it. What was the actual number of deaths? One thing is clear: whatever is the reported number of deaths, the actual number of deaths was higher than that. The debate is around how much higher. It has led to a number of studies, and I have had a chance to look at many of them, and I found that a number of them have made very questionable assumptions to derive certain conclusions. But this is bound to happen if you don't have data on it. And this is where I think if CRS data was available, even for 2020, we do not have CRS data till then formally. So if CRS data was available timely, a lot of these controversies would have been simply avoided. Using that, one can arrive at a fairly good conclusion as to what would be the estimated number of deaths due to COVID. So that's the kind of role that data can play. The availability of data can really make a difference, can inform the policy, can avoid controversy. So I am all for reporting as much data as quickly as possible. Thank you.
Thank you, Dr. I'd like to move on to the next panelist, and we can then maybe open up a discussion on some of these points that you brought up. Professor Menon, do you want to come in next?
Sure, I can do that. So thank you, Ajay, for this invitation, and thanks to Boom for this request to speak here. So we've been involved in modeling COVID-19 in India pretty much since the beginning. And this grew out of an initiative called the Indian Scientist Response to COVID-19, or the ISRC, where we assembled a group of people with some modeling expertise across various different areas, including epidemiology, to try and construct what we thought would be a good model for India to ask us out of questions that we wanted to ask of India. In fact, compute, for example, mortality, numbers of hospitalizations, the number of cases requiring ICU usage, etc. But also to use these models in other ways to try and understand what might be good policy. So the sort of question that we were looking at early on is not just trying to understand the trajectory of cases within India with reasonable numbers that we had, not from India at that time, in fact, not from India for a very long time and even now, but as Professor Kang said, numbers from the West, from China, from Italy, etc., which feed into our models. These are fairly detailed models. So they, for example, they would tell you what is the likelihood that someone between the ages of 20 to 30 with who contracts COVID will have a serious infection that will require hospitalization or not, whether they will die or not. So all of these factor in. So you need to know what, for example, is infection fatality ratio as a function of age or age bracket. All of these numbers go in the description of the demographics of the population, the age distribution, etc., which you use to make more and more granular estimates for different states, for different cities, etc., to how they might be, to how the pandemic might unfold there. So among this, as I said, we're also interested in questions a little away from data, a little towards policy itself. What's the right way to open up? If you wanted to open up, would you stagger up openings? These were questions that were important at the end of the lockdown, of the first lockdown. In fact, the sequence of lockdowns of almost 70 days that we had. So the questions were, when you opened up, should you have opened up altogether? Should you open up in a staggered manner with just 50% of the population? Should you open up all of offices together or reduce that? Should schools be opened, etc.? So all of these are difficult questions which we try to address using modeling methods. And that's where I think models really are useful. It's not really a sort of tracking trajectories on a daily basis, because those numbers are genuinely not very good. And so here I would differ from views that say that Indian numbers are good, etc., compared to other countries, because I don't think that is true. Even now we are seeing cases where Kerala, for example, is adding deaths, backlog of deaths that it was asked to recount to the current number. So these numbers are shifting even as we speak on a day-to-day basis. We know the discrepancy between real cases in terms of serological studies, which look at the amount of antibodies that you have against SARS-CoV-2. Compare that to the number of cases that have been officially recorded as far as the part of testing. In some states, this is the deviation between these numbers is a factor of 100. So for every case that you record, there are 100 cases that you're actually missing. So that makes a mockery of any type of a way of understanding data and predicting the curves of data, because you'd have no access to the right numbers. And the distinction between the right numbers and the number that you record is actually very large. So on this basis, you can say, have states done a better or a worse job of recording numbers? That you can certainly do. And certainly one way of doing it is to look at the discrepancy between a serological study and a study that you get from just looking at official case numbers. This is nuanced, of course, in many ways. We don't really have an understanding based on really large data of how many people are being reinfected. We can make guesses. What are levels of reinfection? What do they depend upon? If you have a prior, if you were infected with a Delta or the original variant or something later, what are the chances that you will be reinfected by Omicron? What is the relative seriousness of the case of your clinical presentation? All of these are numbers that we need to actually add in. So among, I think, the interesting things that we've done from the modeling angle are questions like, when is the right time to open schools? So here we work on fairly complicated models that try to reproduce the structures of families that surround a community surrounding a school. So a community of catchment area of about 20,000 people who feed in children to the school. So you imagine families who go to work and come back, children go to school and come back. You have teachers in the schools who go there and can transmit the infection. And you assume at a certain background level of disease that's already infected the population, when is it safe to open schools? So you can compare a situation where the school is closed with a situation where the school is open and say, do cases go up? How many hospitalizations do you expect, etc. So this really then becomes useful for policy, because then you can say that this state with a seroprevalence of 60% can open schools with no problem at all, whereas another state with a seroprevalence of 35% should consider whether this is the right time. And also make very specific suggestions. For example, vaccinate the family members of school-going children on priority, because the children have not been vaccinated. They will go to school and come back, and they act as efficient vectors to transmit the disease across to the whole community. That's one way of understanding how models can be useful to making very definite policy statements and nuancing them in the right way and understanding what are the trade-offs in a particular course of action. The second thing we did was an interesting question of how do you combine rapid antigen tests with PCR tests? What's the right ratio? Should you do only PCR tests, or can you combine PCR with rapid antigens? Of course, there's an economic perspective here. The rapid antigen test is a cheaper test than the PCR test. It's also a point of care test. You get a result in 15 minutes, whereas with the PCR, typically waiting can go between 24 hours to something like 36 hours, especially at the peak of the Delta wave, when you would recover before your test results actually came in. That's again a question where good models can help policy. And our finding there was that if you tested enough, if you tested at scale, you really needn't worry about having an all RAT regimen. And you really needn't have worried about this whole debate of you're doing too many RATs compared to PCRs. That wasn't necessary. So this again, where, as I said, you can nuance policy and policy understanding by using better model and input from data. Last question that you sort of talked about is, of course, questions around the WHO and undercounting. And I have no doubt that we'll come back to that question again. It's an important question. But there are certainly reasons to believe that we have severely undercounted deaths. I don't think there is any. If you wanted to argue against that, let me put the argument in this way. You would have to say that Indians are special in some way, that there is some Indian exceptionalism or South Asian exceptionalism in some way that should operate. If you take the numbers that we know, the numbers that represent population across the world, and here the crucial thing, exactly as Gagandeep Khan pointed out in the earlier session, is that this is a novel virus. Nobody has any prior immunity to it. There's no question of earlier coronaviruses giving you any special advantage or special exposure that might predispose you to a milder outcome. That's the essence of having something that jumps over, that spills over from an animal host into a human host. The human has no experience of it whatsoever. So there's no a priori reason to assume the Brazilians or the Americans or Europeans or Japanese or Chinese or Indians are in any way different from that point of view. They may have different distributions of ages across the population, but that we can factor into our models. If you assume that that understanding is correct, then you invariably will wind up with numbers of deaths that are at least 5 to 6, if not 8 times larger than the current reported number. That's a simple fact of epidemiology. And it's hard to argue against that, as I said, unless you say that Indians are exceptional in some way. We can argue about the nitty-gritty of how the calculations are done, and certainly there are points of disagreement there, and they could have certainly been improved, but that's the essence of science. There is a back and forth that's required, and we improve our understanding, and we contradict, we challenge what is said. But finally, to say that we should not have this discussion because we have done better than other countries is something that we should not be doing. We should be honest and scientific about the way we approach it. So that's all I had to say, Ajay. Pass it on.
Thank you, Professor Menon. This is a good point to bring in the epidemiologist on the panel, Dr. Laharia. Would love for you to pick up here, maybe share a little bit about your work over the last 2.5 years as it relates to data and some of the lessons. And please do comment on the methodology with questions that we've been discussing.
Thank you very much. So when you are in a pandemic, you need a lot of data to make inferences and to provide solutions. So what we are hearing that there was a lot of good data from India. Of course, on some matters, there was reasonable amount of data and it improved over a period of time. But let me start with what Professor Manindra Agrawal said, that smooth curve. What we need to remember that, of course, India had some of the good data on testing, because that curve report the daily COVID-19 test confirmed cases. And in some period of time, especially when there is a risk of that curve being different, there was those laboratories were functioning to the optimal capacity. So there was no buffer capacity to go beyond. So they were doing whatever could be done. That is my answer to that approach. But of course, we had data on daily reported cases, and whatever data there is there. Professor Menon also reflected about that. What we know that India has its own data, but we also know that in successive sero survey, we know the number of infections were at least 30-fold higher at the national level than officially reported numbers. And now this scenario did not alter over a period of time. Like there are 4 nationwide sero survey, and in all sero survey, we found that officially reported cases to the infection ratio based upon sero prevalence was somewhere close to 30. And what it reflects that even though capacity increased, our reporting of that data did not change. So of course, we cannot say in that setting that we were doing very good job. But having said that aside, there is another dimension which I want to bring in, that even when the data was available, COVID-19 cases, deaths, but we did not have enough granularity or breakup of that data by age, gender, distribution. It might be available in the public government, but it was not available for in the public domain for any outside expert to infer. And one of the big challenges, I just want to give an example for that, like Professor Menon already highlighted about school-related issue, but for example, immediately or in between the second wave, there was a lot of discourse that third wave would affect children. Now, it was very difficult to counter that argument because there was no data available in the public domain from the government that what proportion of children are getting affected. Then, of course, there was some data which is released by the government saying that this at 10% or so is the proportion of children of total infected, but there was no linkage of that data with the severity of the outcome. So infection is one thing, but how many of those were getting admitted? So in absence of that kind of data, detailed data, granularity, it was really difficult to make inferences. And impact was that it was challenging to counter or speak about it, whether children would be affected in subsequent wave or not, because there was no data, and even government took its own good time in responding to that. So there has been a practical challenges or implications of insufficient data in the public domain. I was also involved in one of the study where some of the researcher at Stanford University, that study is out a few days ago in PLOS Global Public Health. We looked at 3 parts, like surveillance, vaccine coverage, and mortality. And we looked at how different Indian states are reporting, what kind of granular data is available. And we found many gaps and a lot of variations between the states in reporting of the data, including on adverse event following immunization, including which AEFI is happening with which vaccine, age groups. In fact, we also found during that analysis that many of the states also reveal the privacy-related information, personal information of individual in the public domain. So India's COVID-19 data definitely has many of the challenges. It has scope for improvement. Of course, one of the things we need to remember that how far we have gone or moved in this direction. We always knew, even before the pandemic, that health data is really not sufficient, not timely, or often incomplete. We know India's health information system, especially the National Health Profile, which is published by Ministry of Health and Family Welfare, Directorate General of Health Services. The numbers on various diseases keep similar for year after year. We also know that those numbers, like the reports from the field facility, do not reach on the time, including on the mortality data, that medical certification of causes of deaths in India at the national level is around 20% of the total deaths are medically certified. So these challenges have been there, and those challenges were amplified during the COVID-19 pandemic. It is very difficult for me to comment, and though I want to say something about it, but it's very difficult for me to, because the data was not available in public domain. So it's very challenging to say whether it has improved anymore or not. I hope that the systems have been created. Of course, we have a little improved data, more timely data, and government asked different state government to send timely data. We heard a few days back when Kerala reported a backlog of cases. Essentially, what Kerala did, because this incident also highlight the challenge of incomplete or non-timely reporting of data. Kerala had a 5-day of backlog in the data, and it reported 1 day. What happened that day? Because of cumulative reporting in day, the number of cases gone up from 1,000 that day to a 2,190% increase, so to say. It really created a panic because every single public person is not going to go and check that why it has increased. So even central government had written to Kerala government saying the report data in the timely manner. So this particular incident highlight why we should improve the data recording reporting system, why it should be timely. And since this happened a few days ago, 2 years and 25 months into the pandemic, it shows that we still have a long way to go. I also want to flag another important issue that many of the researchers, almost every public health person or many of the people who are involved in pandemic are continuously raising the issue that the government should be providing or providing that kind of information where the COVID-19 confirmed cases and then their variant, their clinical outcomes needs to be linked. And that is a kind of next step we need to move on. And I'm not sure, and somebody might be having access to that kind of data, but definitely that kind of data and linkage of the data is not available in the public. I would like to close with the 2 points. One, on the mortality statistics, mortality data for India, I think I agree with everything Professor Menon has said. What is given, that absolute number of the actual mortality in every setting, no matter which part of the world, whether be it India, UK, Europe, United States, would be higher than officially reported number. The only question is that whether by how many fold. In UK, USA, it might be 1.6 or 2-fold, but in India, it definitely would be higher than what the number for other better reporting mortality systems are. So it's given that India's actual number would be higher, and of course we can debate, but we should accept any number coming, acknowledging that there are methodological challenges. But there is no, I would not say that we would outrightly reject those numbers. And final point I would like to make, okay, we should analyze these challenges that data is not available in timely, transparent, or manner in public domain. But bigger question is that, are we going to learn from this pandemic challenge? Are we going to work to strengthen health information system or data reporting system for general healthcare services in the months and year ahead? And that is the moot point. Thank you very much.
Thank you so much, Dr. Laria. I'll now go on to Dr. Singhal. And Dr. Singhal, you as a clinician have been a consumer of a lot of this data and analysis, taking decisions that affect people's lives directly. Would love to hear about your experience with data, the lack thereof, and how the last 2.5 years have been for you.
Thank you, and thanks to Boom for inviting me for this nice discussion. So yes, we are consumers of data, but we are at also a very small unit which is generating data for the country, because we are reporting the number of cases that we have diagnosed in our lab, and we are also reporting deaths. So I just want to tell you where are the shortfalls, because we agree that there is a shortfall. So in terms of detection of cases, the reason there is this large gap between the number of cases and number of reporting is because, one, many people actually don't test themselves, especially if they have mild disease. Then also because, once one family member is infected and the other people have the same illness, they feel that they have COVID and they don't go and test. Third, the tests can be false negative. And fourth, many people actually in the beginning of the pandemic tested themselves late when the false negativity is high. And finally, also in the time of the Omicron wave, a lot of tests were done by the rapid antigen test, which were not reported. So that is also, we probably underestimated the number of cases which were happening. Besides, there were, although our labs really geared up to the occasion, but there were times when, I'm sure in remote areas, in villages, the testing facilities were not that good. So that is why you have this kind of shortfall. Now, in terms of reporting of deaths, because we also have been reporting deaths in our hospital, there is a challenge there. We know that the number of deaths which are underestimated are because of many people who die at home or who do not reach hospitals, especially in the second wave. But it is also to do with some other things. So, for example, if a patient has COVID and the patient has been in the ICU for about 2 weeks and then is moved out to a non-COVID area, and then he finally succumbs a month later because of some infection, that is actually not counted as a COVID death. So it doesn't figure in the statistics, and we in large cities have a lot of patients who have died in this way. And also sometimes, you have a patient, like it happened during the Omicron wave, that you have a patient who has, let's say, a myocardial infarction. And because there is this policy that, when a patient gets admitted to the hospital, a COVID test is done mandatorily, and he turns COVID positive, though the COVID may have nothing to do with his disease, it will be counted as a COVID death. So there are issues regarding reporting as well. So I think that these are some of the reasons why apart from the other logistic issues, these are some of the reasons why you have this kind of gap. But, but at least as a clinician, we find a change in the COVID times, because we have never actually seen data coming in so regularly from the government ever for any other disease. So that data which came in about the number of cases helped us to plan our facilities, how many beds we need to increase. Also, it helped us to benchmark how are we doing compared to other places. So that is how that data helped, even though it has its limitations. I would now move on to an important point about clinicians. Our challenge was more about treating patients, and the data which came out in scientific journals about the treatment modalities, etc., was not up to the mark. And I think everybody knows it because, finally we are doing it for treating patients, and this is a new disease. So when these first patients walked in, we really needed to know, how are we going to treat them? And you can see that there were so many drugs, because even scientific journals fast-tracked their articles, even MedRiv, anybody could publish anything on the preprint server, which would come into the public domain. And many of these articles were shared by WhatsApp. These were not peer-reviewed papers. And most clinicians do not have the ability to really judge whether what an article is reporting is correct or not. And that is the reason why, so many drugs, like, for example, hydroxychloroquine, azithromycin, ivermectin, doxycycline have been widely misused during the pandemic. And, when there was, because everybody was clutching at straws, what can we do to help these patients? And we can remember that, initially there was a paper which said, okay, it may work. And then when other papers came which say that these things don't work, nobody looked at those papers. The kind of trend continued. I mean, the amount of azithromycin, doxy, and ivermectin we have used will cause so much of collateral damage merely because of these publications, which happened. Then we should look at the corticosteroid thing, because what happened is that in June, the recovery trial results came out that corticosteroids are useful in treatment of COVID. And I would compliment that the ICMR did come out with regular publications and telling people how they should be handling these cases. But then it is wrong on the part of physicians, but that this data did come out and it was in peer-reviewed journals, but nobody actually read the fine print about when they should be used, how much they should be used, when they should be stopped. And that led to actually so many deaths because of COVID-associated mucormycosis or the black fungus infection. So even in remdesivir, there was this flip-flop. Even for many other drug therapies, and actually, if you put COVID on PubMed, you find that there are already 250,000 publications. So it is that much of data is available in the public domain, and it is very difficult for clinicians to really sift through and judge what they should do best for their patients. And another infodemic which has happened is that the lay people also know so much about COVID, as unlike other diseases, because of, WhatsApp call, etc. So that when a patient comes to the hospital and gets admitted, he already has information about drug therapies, and they also argue, they may not know. So we also were facing this kind of infodemic, which we had to grapple with. So I mean, we looked at all the other data which came in, but our concern was mainly data which was being published in scientific journals, and how to interpret that and how to treat our patients to the best of our ability. And we also kept kind of changing protocols. There was at one point in time where this convalescent plasma thing came up, and there were publications in favor of convalescent plasma, and they were all observational studies. So whatever publications came were observational studies which had their own selection bias, and they showed benefit. And then we started using these things. And then when the randomized control trials came, that is when we had to actually kind of change. And though some hospitals changed the way they were handling patients, there were some hospitals who didn't change. And this care was not uniform throughout the country. So, I mean, our challenge was that to get correct information about how to treat these patients. And just one more thing I want to kind of tell you is about infection control. So initially, when the guidelines came about how to protect people, there was these guidelines from the WHO, etc. And sorry for that.
ICU 7, bed number 47.
I think I'll just You can take it from here. I'll just pause it. Yeah.
Thank you, Dr. Singhal. We'll pull you back in once you've dealt with the patient that you're dealing with right now. I wanted to go around the room and ask, and I know there's the methodology question that we should discuss, and I guess my request on that, and I'd like to A, discuss it later, and B, my request on that would be if the panelists could sort of very, simply, like I'm 5 years old, explain to me what the controversy really is, and what the competing methodologies are. But before that, so that we sort of stay on topic, a couple of quick questions. We talk about big data a lot, and there was a lot of fanfare around the mobility data, for example, other sources of data being used. In this pandemic so far, how useful has that been for policy, for generating evidence? So we talk about big data for a lot of things. This is probably the biggest test case for big data, and has big data really proved itself? Is there a long way to go there? So that's one question. The second question is, we've also talked about disease surveillance, and if you were advising the Ministry of Health or the National Digital Health Mission on disease surveillance, what would some of your key recommendations be, given where we are right now? So I'll go around the panelists and maybe come to Dr. Singhal right at the end. Dr. Agarwal, maybe we can start with you.
So the two questions that you have, one is that what was the advice to be given? That's the second one. What was the first one?
The first one was, what has been the utility of big data? Right?
Oh, the utility of big data. Actually,
yes.
as far as I am aware, while the big data and data analytics has been of some use, but it has not made a very great impact in the pandemic, probably because the analytical tools were not designed for this purpose, or could be some other reason. I'm not very sure, but I haven't seen a very major impact of something which we got through analytical tools. Regarding the second question, for future pandemics, so similar, the advice would be to report the data in as granular form as possible and as quickly as possible. Because quickly is more important, I could say, because the earlier the data comes, the analysis can be done, the predictive models can be run, and the corresponding feedback be given more quickly.
Thank you, Dr. Agarwal. Professor Menon?
I agree with Manindra that I don't think that the Google mobility data or the sort of stuff that we've got from there has been very useful in terms of being predictive. I think the only real use is to try and understand the stringency of a lockdown in terms of overall reductions in mobility, but nothing very much more useful than that. They may be useful in more granular models, but not with most of the other models that we have currently. So I think there is a role for big data that latches on to your second question. The problem is that the data we have is very patchy and distributed across different government agencies. Ideally, we'd like to know the consequences of infection before and after a vaccination, after 1 dose versus 2 doses, depending upon the vaccination, depending upon a prior infection, and what the clinical consequences are for someone with some pre-existing condition versus without them. If you have combined information about patients, then you can be truly predictive. Right now, we have information about infections, but we don't have anything about the clinical consequences of those infections. We have information about infections, but we don't know whether these people are being reinfected or they've been infected for the first time. We don't know if this is a breakthrough infection following 1 vaccination or following 2 vaccinations. There are small hospital-based studies that Professor Singhal described, but those numbers are small. Technically speaking, all of this information exists with the ICMR, exists with other agencies such as Arogya Setu, Ministry of Health and Family Welfare, and the CoWIN app for vaccinations. But I don't see them as yet, maybe I just haven't seen this, being integrated together with information on the clinical side to be able to be really useful. I think data integration, collection integration are both very important for us to be able to understand long-term what the consequences of COVID-19 are. Regarding surveillance, certainly random surveillance is important. Looking for syndromic surveillance, looking for clusters of cases with similar symptoms across the country, looking at excesses above a background, and at what point will you call that an excess? Doing prompt genomic surveillance on those cases to see is the new variant responsible and what its properties might be. All of these should be part of any long-term surveillance program. I think we're not there yet.
Thank you, Dr. Menon. Dr. Laria?
So I echo everything which Professor Maninder Agrawal and Professor Menon had said. So additional points are there that I believe that in the big data, that kind of appetite in the health sector had not been there to use and interlinkage of that data. So it had not been used sufficiently, but also that require that kind of attention, infrastructure, and prioritization before when it can be used. And when we are in the pandemic, the priority is limited resources were being used very differently. Of course, it could have been used better, but that's the current scenario. Coming to the surveillance part, of course, we would say that in the last 18 years, India had a fairly evolving, and I must say, every passing year, India's disease surveillance system in the last 18 years has strengthened, integrated disease surveillance project, and that's what could be utilized for this pandemic response, including some of the surveillance systems, some of the human resources which were available under various programs, including National Health Mission, which really worked handy. And this is a proof that if you if you want to strengthen any system, be it surveillance system, you need to invest over a period of time. And I must say that the disease surveillance system has improved, and it came up to the up to the certain level during this pandemic period. It has strengthened a fair bit. Having said that, I would still say that the challenge in disease surveillance system is, one, there is not enough investment and enough technical inputs from the subject experts to design those kind of approaches that we can get additional information, ILI or SARI surveillance and other things, though they are theoretically discussed, but the methods and approach are not designed well, not enough allocations are made in those areas. So 2-3 quick points. What should be done? We should definitely, that's the one area where government should commission independent work and see that what are the learning for disease surveillance and how the learnings from pandemic can be utilized for further strengthening surveillance system. Of course, that require a human resource capacity building, some investment, and more importantly, it requires those Indian states which have a weaker disease surveillance system to invest and work on those areas. But the learnings are fairly well known. It's time to intervene, and if governments have desire, it can be done.
Thank you so much, Dr. Laria. Dr. Singhal, I'll come to you if you're free now.
Yeah. No, I just wanted to kind of add that, we are looking at, more analysis of the data which is available with the government, because they have data on deaths, even though that data may be underrepresenting the number of deaths, but at least we look towards publications because they can be very large sets of data which they can analyze regarding what were the kind of people who died in our country, so that we can actually prioritize booster vaccines or new vaccines for these kind of people. Then, as was said earlier, we are trying to look for any integration between the vaccine data and the disease data, infection data, because so that we can know who are these people who are getting reinfections, who are these people who died despite vaccination, and what should be the policy for booster vaccines in our country, because we understand now that COVID has a distinct epidemiology in every other country. So how do we go ahead from here? What should we be doing? Whether we should be vaccinating or not? So, I mean, there are so many questions which are still unanswered. So basically what we are looking for is kind of analysis of the data set which is available because I think there is huge amount of data regarding the number of infections, the distribution of deaths, etc. And as a pediatrician, we are also keen to have more transparency into the disease spectrum in children, because there's nothing available so far that, because we have to also take decisions about pediatric vaccination. And, as a pediatrician, we keep getting this question about, should I give the vaccine to my kid, especially for vaccines like Corbevax, for which there is no peer-reviewed publication yet available. And it should definitely be, because the disease is so mild in children that, the vaccine should be very, very safe. Only then we can recommend. So that is why we need more information about the pediatric disease spectrum, which happened in our country during the pandemic, etc. So, and also some information about how these vaccines performed, what was the efficacy, etc., or effectiveness rather of the vaccines, because right now we have just small studies, but we would like to see, more analysis of the data which has already been collected.
Absolutely. No, thank you so much. And I think with systems like CoWIN, India should be able to produce better data, especially on vaccines, just given that we have large-scale systems already deployed, much faster than many of the Western countries who actually track vaccinations using pen and paper right now. So just to summarize, what I'm hearing here is what would be recommended is granular and timely reporting, a lot of emphasis on data integration, all the way from a positive case to clinical outcomes, which frankly we haven't really seen much of, and also then looking at the disease spectrum in children and evidence around children. Because I also feel, the question I think we'll all ask ourselves is that, what has frankly the impact been on children over the last 2 or 3 years, not from the disease as much as, but from the schools and the schools being closed. And I think we'll only learn more about this as the years pass, especially on learning outcomes, etc. I'll quickly go to some of the questions here. There's a bunch here, so I'm just going to scroll and pick up a few. So one question here was that, did we see a difference, a state-to-state variation in availability of data? Would any of you like to comment on that?
What's that? Could you repeat the question, please?
Did we see a state-to-state variation between different states on availability of data and reliability of data, or was it quite uniform across?
In my experience, it was pretty much uniform across these states. And here I'm talking about the reporting of infections. One can have a lot of debate upon reporting of deaths, and that debate will never end. But infection reporting was pretty much very similar across states.
So I just want to add that for Mumbai, we had this, we could see a dashboard every day which would tell us the distribution of the cases, age distribution of the cases and deaths. And that was actually good, because the UNICEF says that 0.3% of the entire deaths due to COVID in the world have been in children below the age of 18. And when we looked at Mumbai data, it was nearly the same. So I think we don't have this information from other parts of the country. So I would say that Mumbai data, at least there was more granularity. We had more information, and not just the number of infections.
I think just a 30-second point that this is what I was talking about, that we studied the data being reported by various Indian states. That was for a period of 22nd May to 5th of June through online portals, around 100 plus websites. And that's what the paper we have published in PLOS Global Health on 15th of April. It's Varun Vasudevan et al. So the point, what is one of the key findings from that is that data quality was very variable across all Indian states. Some were doing better than others, and there was a lot of variations. And final point here is that we also know through Sero survey, which we discussed earlier, that the case to infection ratio was 1:6 in Kerala to 1:70, 80, or 100 in Bihar, Uttar Pradesh, and Madhya Pradesh, which reflects the overall data recording, but also health system capacity also. So it cannot be a simplistic approach to that, but it conveys that wide variation in the data, and we have studied that.
Can I just come in here? Because I think there is a serious confusion in the meaning being assigned to the quality of reporting. Dr. Laharia has the view that if your reporting is by a factor of 100, then it's poor reporting. If your reporting is by lower by a factor of 5, it's better reporting. I hold a differing view. My view is that if your reporting is consistent, it doesn't matter by what factor it is less. It is good. The reason it is good is because I can estimate by what factor are you underreporting. And then if it is consistent, then I can consistently estimate that. So from the model, I can get actual number of cases very easily. But if your reporting is inconsistent, then I have a problem.
Oh, just 30 seconds. I broadly agree on the second part. That's what I said, that this is reporting the case to infection is also health system capacity, the laboratory capacity, human resource availability. But I was talking about the broader first part. There is a wider variation in the reporting, which is also a data reporting system issue. But second part, Professor Agrawal, I agree with you that modeling can be done, and some of that is definitely useful still.
I just want to add that in our models, we can see how reporting, how this multiplier changes with time. So initially for most Indian states, they were around 100. We were underestimating at least by a factor of 100, 120. But as time went on, that number came down to a factor of about 20 to 30, for example, in states like Karnataka and so on. So this is something you can put into models. It's interesting that you can do that.
Thank you. There's a couple of questions. I know we're coming up on the end of the session. We've got about a couple of minutes. I'm going to skim these questions and pick up the questions that relate to data. There are some questions around clinical evidence, which I think this might not be the best forum to address that. But there's a question here around data, and does the panel suggest decentralized data analyses and resultant implementation, or a dedicated centralized data repository and analysis agency? Which approach is better? How to build capacity for the healthcare sector to better utilize big data?
Well, I would say have a centralized data repository and allow everybody to make use of it. So decentralize the effort.
Yeah, decentralization helps states who are doing a better job, so you know what states to trust, etc. But finally, they should be fed into some sort of centralized system so that the data is just available more easily rather than having to go refer to individual states. So some combination of both of these, I think, allows states to decentralize as much as possible the collection, but still to be fed in at a later point to a common central server.
Dr. Laria, Dr. Singhal?
Yes. No, I agree that, the data should be available for people to analyze, and because there's such I think a lot of useful information can come out from what is available, and there would be a lot of people in statistics, etc., who could do a good job in analysis of this data. But they'll have to set it free, I guess.
Yeah, I have no point.
No, absolutely. I think this is coming out, loud and clear from the panel. As Dr. Agrawal said earlier, it is granular and timely data available in the public domain. And obviously, there'll be different ways of doing that. A couple of quick questions before we close. One is, where is the data? Can you tell us where age-wise data has been published?
Sorry, I didn't get the question.
So there's a question from an attendee, which is, where is the data and where has age-wise data been published on COVID?
So the age-wise data is not easily available. It's only for Mumbai that we have it, but we don't. I don't think we have it for the entire country. In fact, we don't really have any information apart from the number of cases as to this. So that is. But you may have small studies, regional studies, which may have told this. But generally speaking, there is data from the UNICEF and other countries which have published age-wise cases also. But for India, I don't think it's available in the public domain. For Mumbai, we have it. Dr. Laria, you have looked at that data?
No, well, primary data is, of course, with the government, but some of the analysis have been presented by Ministry of Health during the press conferences on the age distribution of various cases. But these have been very far and few, like once in every 3 months or at variable frequency, but the data, so to say, is not available. The analysis or summary reports have been made available occasionally. That's a short point.
Thank you. I think we are at the top of the hour and we've gone a little over the hour. I actually have a lot more questions that I can ask you, and I'm sure the audience does too. But I think we'll have to call this to a close. Thank you so much for spending your afternoon with us, and really glad to have you all.